right, let's get started then. So welcome everyone to the February 21st session of the Virtual Learning Collaborative, developing an annual surveillance publication to increase public awareness and access to viral hepatitis data, made possible in partnership with the CDC's Division of Viral Hepatitis. My name is Isabella Chuga. I use she, pronouns, and I'm an associate director on the hepatitis team here at NESTED. So I'm very excited for today's session. Joining us today are presenter Larissa Wilberschied, who is the program manager for hepatitis B and C surveillance in the Bureau of Hepatitis Healthcare and Epidemiology with the New York Department of Health, and moderator Danica Kuncio, who is the Viral Hepatitis Program Manager with the Philadelphia Department of Public Health, and is also a HepTech Advisory Committee member / consultant. So for today, the format of the session, we'll start with a presentation by Larissa, then we will have a moderated discussion by Danica. So feel free to use the chat to introduce yourself and your jurisdiction and for any questions you have. So I think with that, I'll turn it over to Larissa.
Great, thanks, Isabel. I'm going to try sharing my screen. All right, do you see my slides? Great. Okay, so like Isabel said, I've been asked to talk about our annual report, how we developed it, and how we use it to increase public awareness and access to our viral hepatitis data. And then I just have to figure out how to go forward. Okay. So before I do that, though, I wanted to give a little background on the organization of hepatitis activities in New York State. So New York State is actually comprised of two separate CDC reporting jurisdictions. We have the New York State Department of Health, which is where we're located, and then we have the New York City Department of Health and Mental Hygiene. The New York State Department of Health is responsible for hepatitis surveillance and case reporting for the entire state, with the exception of New York City, which is the responsibility of our colleagues at the New York City Department of Health and Mental Hygiene. And although we work really closely with our New York City colleagues, our surveillance systems are separate. And so for that reason, the annual report that I'm going to be talking about today covers only hepatitis B and C in New York State, but not including New York City. And New York City publishes their own really excellent report, which if you haven't seen, I suggest you take a look at. So to give you an idea as to how we're structured at the New York State Department of Health, the Health Department has two main divisions. And until May 2022, hepatitis C programmatic activities were housed in the AIDS Institute, while all of the hepatitis B and C surveillance activities were housed in the Center for Community Health. Okay. And the Center for Community Health is also where perinatal hepatitis B and hepatitis A activities are housed. But starting in May 2022, the hepatitis B and C surveillance team moved over to join the Bureau of Hepatitis Healthcare and Epidemiology. And so now all of our prevention, testing, linkage to side by side with hepatitis B and C surveillance activities. And this reorganization has really facilitated a lot of our work, but there are still some hepatitis activities such as the perinatal hepatitis B and hepatitis A, which remain in a separate part of the health department. So we still have a really important need for collaboration across the health department. So we've produced a variety of hepatitis data products on an annual basis. We put out a comprehensive annual report, a series of one-page regional data briefs, slide deck, and then we also partner externally with the team from the City University of New York to publish hepatitis C data on the New York State hepatitis C dashboard. We've been publishing the comprehensive hepatitis B, C annual report, the regional one-page summaries, and the hepatitis C slide deck since 2017. Since the annual report aims to pull together hepatitis B and C data from a variety of sources from across the health department, it's always been a collaborative effort. We work with the owners of different data sets to obtain hepatitis data that wouldn't be published otherwise. And I just want to emphasize that for us, this work has really always been very much a team effort. The core team that's responsible for creating the report and accompanying data products has ranged from as little as 3 people in the early years, and that was actually less than 3 FTEs, to as many as 8 most recently. But not everyone on the team is necessarily working on the report at the same time, but everyone does have their own piece or pieces to contribute. The way we've divided the work up between the team has varied from year to year. We're really still trying to figure out what the best way to balance the need to share the workload while also ensuring that the data, the style, and the language are consistent throughout the documents. Just to give you an idea as to how long this takes us, last year we started working on the report in June, and we had it finalized and ready to go through our approval process by mid-October. So the work spanned about 4.5 months. The style of the report and the data products has evolved over time as we've really tried to make them more engaging and user-friendly. The earlier versions of the report consisted primarily of graphs, a lot of data tables, and a lot of text. And then more recently, the main body of the report is a lot more visual, with text limited to just highlighting some key data points. The data tables are still available for those who need them, but we've moved them back to the appendix. To give you an idea of what kind of software we use SAS to analyze the data and create most of the maps that you'll see. We use Excel to create the tables and the graphs, and we use a combination of Word and Adobe Acrobat Pro to create the body of the report. And then we use PowerPoint for the slides and also for the regional one-page summaries. So supplementing the 3 data products that we produce internally, I also mentioned that we collaborate externally to create the hepatitis C elimination dashboard, which I'll talk more about later. The basic content of the report has been similar across the years. We've published hepatitis B and C epidemiologic data, including age, sex, race, ethnicity, county, and risk factors. We published hepatitis B perinatal vaccination coverage data. This is the first year that we included the Hep C laboratory-based clearance cascade using the CDC definitions. The report also includes hepatitis C programmatic data from our testing, linkage to care, and treatment initiatives. We published data on hepatitis B and C mortality trends. We also include results from an ongoing hepatitis C seroprevalence study among incarcerated persons. And when we have it available, we include hepatitis C data from New York's BRFSS survey. In 2021, that's when we updated the look of our reports. We tried to make them more visual, like I said, and less text and data table heavy. Hep B and C sections of the report each have roughly the same type of surveillance data, content, and visualizations. And for the next however long, I'll be showing some screenshots of the content to give you a flavor of what it looks like. But for the most part, I'm not going to be talking about the data itself. And you'll see some of the slides are a little blurry. I apologize for that, but I was taking screenshots of the report, and once I blew them up, they got a little distorted. But you can always find the originals online if you want to take a closer look. So here, just showing you that we provide trends in case counts and case rates with a couple of call-out boxes that describe the extent of increase or decrease over time. We also report on case counts and rates by geographic area. These county level maps were created using SAS. Creating new maps in SAS, for those who haven't tried to do it, is not the easiest thing to do because it's all done through code, and it's hard to figure out how to fine-tune the details of the maps. But at the time when we first created these, we didn't have access to any other mapping software. And on the plus side, once you create the code, it's pretty easy to update using new data from year to year. However, I do anticipate that we'll be moving away from using SAS for our maps and hopefully move towards using Tableau. Data on hepatitis B perinatal vaccination coverage are provided by our colleagues in the perinatal hepatitis B program. And this is one example of how this report is the result of collaboration across the health department. Oh, let me just go back. So you'll note that the last several slides have all been on a light blue background. So we color code the hepatitis B and C sections of the report to make it easier to find each section when you're flipping through the pages. So this year, the hepatitis B pages were light blue, and the hepatitis C pages are light purple. I'm going to point that out. So while we are challenged by incomplete data for race, ethnicity, and risk factors, our data on age and sex, we don't really have data on gender, are pretty complete. And by leveraging just the age and the sex data, we really can learn a lot, and we really tell a lot of stories with that data. So for example, on the top left, we've highlighted how the distribution by sex differs across the age groups. We've used the data to call attention to hepatitis C among women of childbearing age here. And on the right-hand side, we've used it to describe the shift in age distribution from the older to younger populations. As I mentioned before, we try to use text sparingly to call attention to the key takeaways. Here on the top right, we explain the significance of chronic, acute, and perinatal hep C. And on the lower left, we'd highlight the need for RNA testing and RNA reflex testing. We found that the burden and epidemiologic profile of cases varies across the state. And so for that reason, we also look at trends at the regional level. On the top here, you can see at the regional level, the number of cases and the case rates for each of the regions. And this map on the bottom, unlike the other maps, this map was created using mapchart.net, which is online, free, and really easy to use. The regions were manually shaded using the application, and then we added the text later. So this, for anyone who doesn't have access to mapping software, this is a low-tech and free way to display data by geographic area. We publish risk factor data for both acute and chronic hepatitis B and C. Our risk factor data is not as complete as we'd like it to be. And so what we do is we present it both with the missing data and without the missing data. Although when we tend to describe our data, we tend to describe the percents among cases with available risk factor information. 2022 was the first year that we published the results of the CDC laboratory-based Hep C clearance cascade. Negative RNAs were made reportable statewide in 2016, so our cascade starts in January 2016. New York State supports several initiatives where we fund providers to provide hepatitis C testing, linkage to care, and treatment to underserved or populations highly impacted by Hep C, including people who injected drugs. So information from those initiatives is collected through a different data system called AIRS, which is separate from our surveillance system. And our annual report includes data briefs from each initiative, highlighting the demographics of the population served, a care continuum, and some other key data points. So this slide shows key demographics of patients enrolled in one of our initiatives. And this shows the Hep C care continuum for the same initiative. We use CDC Wonder to track liver cancer, hepatitis B and C mortality trends. Because Hep C deaths are more common than hepatitis B, we've been able to provide some more detail for Hep C mortality, including looking at trends in race ethnicity, like you can see here in this graph. Because CDC Wonder data are suppressed for subgroups with 20 or fewer deaths, we did have to get creative in order to present data for the Asian Pacific Islander and the Native American populations. We only present mortality for Asian Pacific Islanders for the years where there were more than 20 deaths. You can see it here on the bottom of the graph. And in order to report out on the Native American population at all, we had to aggregate the years 2012 through 2020 and describe it in the text box over on the right-hand side. Prior to 2020, we were publishing our annual mortality data just for New York State outside of New York City, excluding the 5 counties or boroughs of New York City from our queries. But CDC Wonder has changed, and so we can no longer obtain age-adjusted mortality rates for a subgroup of counties in the state. So we had to adapt, and so now we just report statewide mortality, including New York City. New New York's hepatitis C elimination plan identifies correctional facilities as a priority setting and people currently or formerly involved in the justice system as a priority population. New York State's corrections system tests all individuals at intake for hepatitis C and tries to ensure that anyone with hepatitis C is treated prior to being released. We have a really strong partnership with our state corrections colleagues, and so we really felt it was important to provide some of this data specifically in the report. So we were able to do that for the first time in 2022. So here you can see we've included a summary of just individuals who were first reported from our state correctional facility, including case counts, rates, and some other basic demographics. Our HIV/AIDS colleagues elsewhere in the health department conduct regular sero studies among individuals entering the state correctional facility, and they obtain HIV and Hep C antibody and RNA results, as well as risk factor data. They are kind enough to analyze and provide the hepatitis C specific data and the HIV Hep C co-infection data for inclusion in our report. These sero studies are conducted every few years, so when there's new data available, we'll include it in the report. There wasn't any available for our 2022 report, but this graph is from our 2021 report. And since negative Hep C antibody tests are not yet reportable in New York State, this sero study is one way that we can track trends in hepatitis C antibody positivity, at least in this important population. And these sero study data are another example of the value of collaborating with our partners across the health department to pull together relevant data from wherever you can find it. Until we started publishing this data in our report, they weren't readily available to the public. From 2019 to 2021, we added 3 questions to New York's BRFSS survey to try to get a measure of hepatitis C testing in the general population. We asked about hepatitis C testing, diagnosis, and treatment. Starting in 2023, though, we're just going to be asking about Hep C testing. We didn't really get much value out of those other 2 questions because it's such a rare occurrence. But we're hoping that the question about testing will help us see the impact of New York's universal hepatitis C testing law, which will go into effect in May 2024. So while we recently removed the data tables from the main body of the report, we felt that it was important to provide them for those looking for that level of detail. So we still include them, but we've just moved them to the appendix. This example shows our race and ethnicity data. So like I mentioned before, we're still grappling with incomplete data, especially on race and ethnicity, and we are trying to improve the completeness of these variables. We've been using several other data sources, but our completeness is not yet where we really like it to be. Race and ethnicity data are collected separately and are more complete for race. You can also see over here, percent unknown for race. They're more complete than ethnicity. So in order not to lose the information that we do have, we don't combine race and ethnicity so that we don't try to report out on non-Hispanic white or non-Hispanic black. Because if we were to do that, we would just have a whole lot more missing information. So we just continue to report out on them separately. Our second data product is a series of 9 one-page regional Hep C summaries. Like the report, we've been publishing them since 2017, and we upgraded their look in 2018. These data briefs seem to be really popular. They're still data focused, but they're designed to be more easily digestible for those who just want a snapshot of hepatitis C in their region. We've heard from some providers that they had no idea that Hep C was as big of an issue in their area until they saw these summaries. I'll show the content of one regional summary in more detail in the next couple of slides. So each regional summary has a series of bullet points that highlight the key epi-trends in the region and a graph showing the case counts and the case rates for each county in the region and how those rates compare to the regional rate and the New York State rate. Each summary also includes a trend comparing the regional rate to the New York State rate. a graph showing the extent of injection drug use reported by individuals less than 40 years of age or 40 and older, and case rates by age and sex. And each of the graphs is accompanied by a brief takeaway message. If you were to compare these regional summaries across the regions, it really gives you an idea as to how the demographic profile varies across the state. Our third data project is a slide deck. Every year, we create a standard hepatitis C slide deck that's comprised of some of the visualizations that are in the annual report, as well as a few other slides that summarize key data into a single slide or help to make important points, or for situations where we need an alternative to presenting data in graph format. And there's just a couple of examples here. These slides are used for presentations conducted by our own staff, as well as colleagues elsewhere in the health department. And not everyone who uses the slides is equally comfortable talking about the data. So we make sure that the slides include speaker notes to provide more context and accurate language for describing the data and their implications. So the last data product I wanted to talk about is the New York Hepatitis C dashboard. The dashboard's not created or maintained by us, but it is an important collaboration between the New York State Department of Health, the New York City Department of Health and Mental Hygiene, and then our partners at the City University of New York Institute for Implementation Science in Population Health, and they're the ones who actually developed the dashboard. The basic structure for the dashboard was adapted from New York's HIV/AIDS Ending the Epidemic dashboard, so we really didn't have to start from scratch when we created this dashboard. In addition to publishing information from our Hep C elimination plan, key milestones towards Hep C elimination in New York State, the dashboard is the one place where we can present statewide data that includes New York City. And we're able to do this through a data sharing agreement with our New York City colleagues, where each year they give us selected patient level data that we combine with our own surveillance data to produce a deduplicated data set containing all individuals diagnosed with Hep C from 2010 through the current year across the entire state. We provide aggregated data from this data set to the dashboard team, who then creates interactive data visualizations. The interactive format of the dashboard allows a user to examine trends in diagnoses and treatment clearance for whichever geographic or demographic areas are of interest to the user. So for example, you can look at trends for any or all regions of the state. You can look at trends for any or all age groups, or you can compare a specific county to the larger geographic area in which it's located. And then in addition to the trends, the diagnosis and treatment clearance data are available in map format at the region level, the county level, New York City neighborhood level, and New York City boroughs level. So we talk about dissemination. We use a variety of approaches to get this data out to people who can use it. The annual report and the regional summaries are posted on the New York State website with multiple ways to get to the reports online. So people who navigate to the website, to the surveillance sections of the website, or to the consumer and provider sections of the website will find a link to the data reports. We announce the publication of the report through a variety of listservs. We send it out to our partners at the local or county health departments and to all of our funded providers. We also conduct multiple in-person and virtual presentations. First, we start by sharing and discussing the results internally with our hepatitis C program and prevention coworkers. We use the data internally to inform our programmatic work, as well as resource allocation and policy development. It's also important to ensure that our colleagues across the health department are aware of the current hepatitis trends, because there's a lot of ways in which we can leverage resources across the program areas, and sharing the data really helps us make our case for cross-program collaborations. Our organization has regular staff meetings. One of them just ended a little while ago. It's attended by staff who work in HIV/AIDS, sexually transmitted infections, and drug user health. And this meeting is a really great venue for sharing these data with our colleagues who might not think about hepatitis as much as we do. We also present the information to external partners, stakeholders, whenever we get the opportunity. This has included a virtual bi-monthly hepatitis call with our 57 local health departments, the New York AIDS Advisory Council, the Latino Commission on AIDS, the New York Correctional Health Initiative Provider Conference, and the Clinical Education Initiative, which is a New York State Department of Health AIDS Institute program that offers continuing medical education for providers. And we also present the data to our funded providers during one of several regularly scheduled meetings. And this really helps to ensure that these data reach those who provide care and services to those populations highly impacted by Hep C. We recently used the slides to support presentations about New York's new hepatitis C screening requirements to provider membership organizations and at regional meetings. We presented the data at regional and statewide hepatitis C elimination meetings that are attended by a mix of people, including community members, providers, community-based organizations, local health departments, and just people impacted by hepatitis C. Because the reports are posted online, we've also found that external partners have just found their way to them and incorporated screenshots from the report or regional summaries into their own presentations. And I think that really helps to further spread the word to even larger audiences. And personally, it makes me happy every time I see one of our visualizations show up unexpectedly in someone else's presentation. So when we published our 2022 annual report, we also put out a press release, and it happened to get picked up by several news organizations. That's one more way that we try to get the word out to the general public. And then, of course, there's the dashboard. The dashboard promotes the dissemination of Hep C data, in part because it's interactive and public-facing, but the dashboard team also publishes blog posts on the dashboard and on social media, including Instagram and Twitter or X. And dashboard users can also sign up to receive any future updates about hepatitis C elimination topics. And we've heard from a variety of dashboard users, including other state health department staff, county health department staff, and community organizations. They've found the dashboard helpful and use the information in their own work. And personally, I go to it pretty frequently to slice and dice the data in ways that we haven't already done in our annual report. So just to wrap up, I wanted to show a few examples of how our hepatitis data has made it into the media or social media. So on the left, it's our press release announcing the publication of the annual report that went out on November 22nd. And it was picked up by a reporter at Newsday who specializes in health reporting, and the article was published 2 days later. And then lastly, the Instagram posts on the right are the work of the dashboard team, and they're based on the data that we provide to them. And I think that these posts are really the best example of where the data is really distilled down into the simplest of messages. And I'm going to end right there. Any questions? I can't see the chat. So.
This is Danica. That was a really great presentation. Thank you so much for going into detail about how you guys worked through this entire process. You guys have done it for a number of years, so being thoughtful and throughout the development and evolution of this is very clear. So thank you for sharing with us today. One question I have that might be on the minds of a lot of, especially the EPIs on this call, could you talk about the timeline for creation of this? I know it's a team effort. It requires multiple data sources and teams working together, but just the sheer number of visualizations and tables you all have must take quite a bit of work. So I'm wondering if you could speak to the time it takes and the workload it requires for putting a report together.
Yeah, so I mean, it took us about 4.5 months. We started with, I think, creating just the data aggregations that were needed using SAS. And I think at that point, we kind of paused and proofread the aggregations before we started incorporating them into the report. I think any new visualizations that we tried for 2022 take a little longer than if we're just repeating something that we've done in the past. So to the extent that you can keep the same format from year to year, you'll save time. There was a lot of proofreading and editing that has to be done, and I think that's inevitable. You have to expect that because no matter everyone's best efforts, there's going to be differences in how data were aggregated or different visualizations that need tweaking, and so like don't make sure that you allow lots of time for proofreading, and you also should expect a certain amount of annual report fatigue. And at that point, it's really hard to see any mistakes or anything that needs to be edited. So at that point, it's really helpful if you can have a fresh set of eyes, if you have someone to spare. Yeah, and I think don't underestimate how long it takes to like pull all the pieces together. So you might have the individual graphs, or you might have the hepatitis B and the C section, but you need to combine it with your program data. And just that by itself can take a while because there's a lot of formatting in the report and it can be distorted as you combine the different entities together.
There's a question in the chat asking for clarification on whether what the time frame was for creation of the report versus administrative review. How proportionally how much time did you spend actually making it versus the obviously very necessary edits and administrative review, but was that disordinate to?
It was longer than we wanted it to be. It's hard to quantify because there's review is happening like throughout the process. I think initially we wanted to try to like designate October or September as review month, but it just didn't work out that way. So I would guess maybe, I don't know, a third of the time, Lindsay? I would guess about a third of the time. She's agreeing with me.
for administrative review.
Yeah.
Okay. Well, that makes sense, and I know we all have to deal with the layers, so always good to get a jump on it as soon as possible. Are you guys do you start as soon as the data's closed, or do you wait until okay?
Yeah, so we close our data at the end of May, beginning of June, and we start pretty much immediately.
Yeah. I had another question. So this is something we're always grappling with too, and I'm sure others as well. Just thinking about data presentation. So you guys put your data tables in the appendix. Those can be really difficult to interpret, obviously, and you've moved more towards a visualization route. I wonder if you have any insight on the text component, how you choose what pieces to highlight, and use text to do that versus using a visualization to highlight something in your report. And that might be too granular, so feel free to defer, but.
Well, I think we don't use text in this year. We didn't use text separated from the visualizations. So every text box was somehow associated with the visualization. We leave a lot of the details that we used to incorporate into the main body of the text in footnotes, or refer the reader to either our technical notes at the beginning of the document or to the data tables at the end. So for example, if we're talking about data by sex, we feel that it's important to indicate, that we don't have data on gender available. So we explain that, I think, in the technical notes. Or if we're talking about data by race and ethnicity, our footnote will include something about the extent of missing information for race ethnicity. Our technical notes also highlight the fact that the case definitions have changed over time, and that really impacts how you interpret trends over time. I think of anything else. I mean, I think our main points tend to be pretty consistent over the years. We try to highlight women, people of reproductive capacity, and the impact of hepatitis C on that population. We try to highlight the impact of injection drug use and the change in the age demographic over time and how that correlates with like the opioid epidemic. And I'm talking primarily about hepatitis C because we spend most of our time thinking about hepatitis C. Unfortunately, we don't have quite as much time to focus on hepatitis B.
Double-edged sword for sure.
Yeah.
Alan has a great question. Were there any information or graphs that external partners or the public asked explicitly for that you weren't expecting but turned out to be an important data point to be including in the report? And are you open to requests for data that you then put into the report?
We are. I don't know that we've gotten too many requests. We did actually have a conversation with a very active community member recently. And based on that conversation, we went back, or at least I went back to look at some of our data in a new way, and we might be able to incorporate that feedback into a future report. And that was focused on hepatitis C in the older population, actually, which is kind of not what we've been focusing on.
Do you have any tips and tricks or advice you would give to jurisdictions that are first setting out on this report journey?
Data, I think I mentioned it already. You can really do a lot with just age and sex data. I don't know if anybody has really great race and ethnicity and risk factor data, but I wouldn't worry about that. So just leverage the data that you have and try to look at it at like regional levels, because it was kind of surprising for us to see how much it varies across the state. And it makes a certain amount of sense because like for years we've been seeing that like New York City's age breakdown was very different from what we see outside of New York City. But as we look at counties that are closer to New York City, their age distribution is closer to New York City's age distribution than it is in the rural parts of the state. So, and knowing that can really help you kind of target your efforts in those particular regions. So regions that are closer to New York City, maybe they're not going to have quite as much success trying to reach out to the young population and get them tested for Hep C. Maybe they still need to spend more time looking at their older population. And then in terms of creating the report, try to set it up so that you can just kind of plug and play in future years. So like if you use SAS to do your aggregations, try to set it up so that you have like macro variables where you only have to change like one or two things at the top of your program and you can just run the same exact program the next year with minimal changes. If you're using Excel, try to set up your graphs so that you can just paste in the new data into your data table and you don't have to make any changes to the actual graph. It can be a real time saver, I think.
That's helpful. Did you guys start with a shorter report and just build on it piece by piece, or is this version that you released in 2020?
I think it's gotten longer over the years. We like to add things and we don't seem to want to take things out. However, we have tried to make it easier to navigate. So for 2022 was the first time we were successfully able to add a table of contents with hyperlinks. So someone can just read the table of contents and jump to where they want to be, whereas in the past, they would have to scroll through to get to the section that they wanted.
There's one more question in the chat, and then I want people to feel like they can I don't know if they're allowed to, I don't know if you have the capability to pop off mute and keep opening this up for folks to ask specific questions themselves. Isabel says yes. So I'll just ask Leilani's question. How do you select topics for your data briefs? And how do you disseminate those? Do you do it similarly to the reports, or how do you get that information out?
So the data briefs are really just the regional summaries that I've referred to. I think I've used different terminology to refer to them, but so there's like 8 or 9 of them. We disseminate them pretty much the same way, because there's a link to them in the press release that gets sent out. When we send out the report through our listserv, they get links both to the annual report and the data briefs. And there was a conference recently where we brought some printed out copies of the annual report and the data briefs, and it was actually those data briefs that people grabbed up and took with them because they really liked, I think, the fact that they were short.
I'm going to open it up to folks. If you want to raise your hand, we can have you come off mute if you have any specific questions. While everybody's getting brave and deciding what they want to say, one additional question I have, you were speaking about comparing the regional jurisdictions to each other and that was really some interesting information. I'm wondering if you guys have considered looking at any population normalization or adjusting of your rates, looking at, I know race ethnicity is complicated and incomplete, but looking at that compared to the demographics within a jurisdiction or the whole state, to see if there's any disparities or inequities that your work could be focused on.
Well, you mentioned race and ethnicity. We don't look at race ethnicity at the sub-state level, and that is because when we look at data at the county level or at the regional level, we exclude individuals who are reported by the state corrections facilities. And that's because they're not thought to be in the community. And so counties don't really want those counts included in their county specific information. So by taking them out, you think about it, it causes some problems if you try to look at race ethnicity of the Hep C population in that county compared to the population as a whole, because the census data will include individuals in state corrections facilities in the county in which the facility is located. So that's going to tend to be more minority populations. So like in a small county, that's going to disproportionately impact the race ethnicity distribution of the county population. And then you're taking those individuals out of your Hep C counts and they kind of disappear. So it's kind of problematic to look at race ethnicity at the county level.
Do you do it at the state level though?
At the state level, we're kind of exploring our options. So up until a few years ago, we did used to compare the percent of patients in each race ethnicity compared to the population overall. We stopped doing that for the last couple of years, but I think we're actually going to be moving back towards that. Part of the reason for that was, first of all, it's a lot of missing data, but also we weren't happy with the data visualization that we were using. We have some new ideas for how to do that though.
There's some questions in the chat. Isabel is asking about using CDC Wonder. And Isabel, I don't know if you want to come off mute and ask your question in more detail, but
Yeah.
Okay.
Oh, sorry. Yeah, I was wondering, you mentioned that you were previously using CDC Wonder and then something happened and now you're not using it like you were previously?
No. No, we're still using it. It's just that we used to be able to report out on mortality for New York State outside of New York City. But now we can no longer look at age-adjusted rates for a subset of counties in New York. They don't provide that information. So now we have to look at mortality for the state as a whole. We can't break it out by rest of, what we call rest of state, New York State outside of New York City.
Got it. Thank you. Oh, that's a good thing I clarified. You clarified that. So how is that impacting programmatic decisions, or if at all?
Well, it's really just the mortality, so it hasn't really impacted it much.
Okay, got it. Thank you.
Lauren asked a question about your the way you're collecting sexual orientation and gender identity. Do you have are there any intentions statewide or within your programs to be collecting more than the gender assigned at birth or sex assigned at birth?
So I suspect that this is true for most jurisdictions. Most of the information that we get on patients is limited to what's on a laboratory report. And so laboratory reports will report something. It tends to be male or female. We don't know for sure whether that is sex at birth or current gender identity. We have no way of knowing. We assume that it tends to be sex at birth. Our surveillance system has the capability of capturing information on gender, but it's blank for more than 95% of records, just because we would only get that information through case investigation. The local health departments have limited resources to do the case investigations, and so case investigations don't tend to be completed for most of our cases. So we're able to collect it. We just don't have those fields populated, and we don't have the resources to it.
Thank you. It sounds like Leilani has a question that's more about the actual data in your report. I don't know if you want to answer her question. She's curious about females in correctional settings having a higher Hep C seroprevalence than in the general population. She's saying it's counterintuitive, though we've seen similar trends. I have an explanation for us, but I'm not sure what yours is.
Yeah, so you're referring to the slide that's looking at Hep C antibody positivity. We think, well, I would guess that it has to do with the reasons that the females are in the state corrections facilities. So it's probably, and I don't have the data to back this up, but my theory would be that the reasons that they're being arrested and convicted are adjacent to things relating to injection drug use or other risk behaviors, whereas the male population probably has a wider range of things for which they're convicted. Yeah,
that's our theory too. And Amber says they see the same thing in HIV. Does anybody want to pop off mute and ask any questions? Or pop them in the chat and I'll say them out loud. Don't worry.
Hi,
Okay.
Larissa. This is Lauren Orcus again.
Thanks, Lauren.
I have a question just about I'm looking at the Hep C trends over time, and nationally and seemingly other states are seeing a similar decrease since us and PA's 2017 really dropped off. Have you been asked to explain any of that?
To explain the decrease?
The decrease, yeah.
Well, I haven't I suppose we've been asked, but I mean, I guess it's hard to know exactly why. We don't know at this point because we don't have negative testing reportable, whether it's due to a decrease in testing rates, or if we're just, maybe we've already diagnosed the easy to reach population, and now the people who have not yet been diagnosed but who have hepatitis C are the harder to reach population.
That's helpful. I am just anticipating in us publishing our first annual report here in the next couple of months that it looks pretty dramatic decrease. You know, it will probably be asked to at least to conjecture why. So that's helpful. But I do appreciate the text sort of statements in here in addition to the figures. So thanks for talking about that, because it seems like places do that differently. So I hope that was helpful comment.
Related, Alan put something in the chat about how do you decide what trends are reliable enough to publish? Are you guys doing any quality assurance, quality control stuff? They have delays in reporting and diagnoses and things like that. So how do you guys approach what you're confident is clean enough data, or is data that is representative of what's really going on and not?
Can't say we have any systematic way of doing that. We are more hesitant about drawing conclusions about some of our missing data variables, so race, ethnicity, risk factors, but we're pretty confident in conclusions or what we're seeing in terms of our data by age and sex. I can't say we have any systematic
Do you do any QA/QC with laboratories every year to see, are there changes?
Oh yeah,
What's being reported?
Funny you should ask that. That is actually one of my projects for this year, is to try to come up with some sort of lab audit system. A couple of summers ago, we did a one-off analysis at the lab level, trying to determine which laboratories appeared to be doing reflex testing. And we identified laboratories that appeared to have very low reflex testing levels, or even more concerning, decreasing percentages of positive antibodies that were followed by an RNA test. We've reached out to some laboratories. It's been a very labor-intensive process to reach out to these laboratories, because first we have to get them on the phone. And then the couple of laboratories that we've actually been trying to work with, it's been months of trying to get them to resubmit the correct laboratory data. Once we get it, it's not easy for us to put it in our system, but we're kind of in the process of trying to assess how effective these communications with the laboratories has been, and whether we actually get improved data from them. So anyway, we're hoping to come up with a more systematic way to assess lab reporting drop-offs. But we haven't gotten there
A
yet.
continuous struggle. You only know what you know, but
Yeah.
you want to be able to confidently talk about it. So Alan, I know what you're talking about. We always hesitate to what are we presenting? Do we feel confident in it? But at a certain point, you say we're confident enough, I guess.
You have to go with what you've got.
Yeah. Stephanie in Ohio had a question, and she's asking about using in your report, are you using confirmed only for acute and chronic, or do you combine probables with confirms?
We include probables and confirmed. We don't include those patients who have the positive antibody and a negative RNA, though, initially.
When you're talking about all of this incomplete data or unknown data, how do you approach it for different communities? It's one thing to be talking to EPIs about it, but how do you speak to the community or different populations or different stakeholders about missing or unknown data, and why we can't necessarily, or why you can't necessarily show some findings?
Well, we try to always preface it by explaining that the data are limited, and sometimes we will go into a little bit more of an explanation saying it's limited because it's not reported on the laboratory report forms. We try not to get into the weeds explaining why the data is missing and what it means. So depending on the population, we might try to avoid having to talk about the data where it's missing for a lot of people. In the annual report, we tend to rely on the footnotes to provide that additional explanation. And on slides or when we're talking about it, we'll tend to preface it by saying, like among individuals with known risk factors, X% reported injection drug use. Qualifying it to indicate that it's only among those who have known information.
Kind of tangential to that. So thinking about different ways to disseminate in different communities, you're doing outreach to. You guys have a variety of ways to get this information out. Are there key populations or communities that you work with to disseminate the information? I know you went through like your listservs and things like that, but do you specifically, target any groups to sit them down and show them this information to really walk them through what it means and make sure that the community members know what's going on?
I think we do that more with our HIV populations because they overlap a lot with our Hep C community members. And they're the ones who tend to have organized meetings where they ask people to come and talk about hepatitis C. So we definitely have that opportunity. And then I mentioned that we have our annual elimination meeting, and that's attended by a variety of community members, community-based organizations, and so on. So we try to just present the data in simple terms, and then we're always happy to meet with people individually if they reach out to us.
Do you publish this with a certain level, with a certain reading level in mind? Does it go through any language access approvals?
No, it does not.
Epi's
That's
tough.
a good idea.
It's just another thing on the list. All right, well, we have only a couple minutes left. I just want to give anybody else an opportunity to bring any questions to the group. Does anybody have any of their own insights they want to share for aspiring report makers? There's some beautiful reports out there. I know it.
This is Lauren again. Sorry, in the last minute here to open up a can of worms, but with our first iteration of our annual report, we ended up deciding to use the counts from previous years, even though we have an idea that maybe data cleaning wasn't altogether perfect. So we kind of went back and forth at first about whether we reclassify them, but we ended up going with what had been reported to CDC. So I just wanted to mention that in case it's helpful for folks starting out.
Thanks, Lauren. Jeffrey also put out there, be patient. I think that's a really good point. Take your time. Something that we've done is you don't need to start with a beautiful 55-page report like New York State. Bite off the pieces you can and take it step by step, build on it over time. If you can do what was recommended and be able to more easily replicate each year and just fill in the updated data, then you can be taking the time to build on it. But I agree with all those statements. Wendy also said the commentary about your slide set is an incredibly helpful observation, and thank you for that. I agree. I think that's a great piece of advice for dissemination. All right, everyone, we're at time. Thank you so much. Isabel just dropped all of these links in the chat. Thank you, and bring all your report questions to each other and share with Isabel so we can get them out and we can inspire one another. Thanks, guys.
Thank you.